Hello, everybody. Thank you for being here. And I'd like to begin by thanking our speaker, vascular neurology specialist and Washington University School of Medicine professor of neurology, Dr. Renee Van Stavern. That's a mouthful, Dr. Van Stavern. Stroke is a leading cause of death and serious long-term disability. According to the CDC, someone in the United States has a stroke every 40 seconds. And that's why it's so important to learn the signs and how to act quickly. So without further ado, I'd like to introduce neurologist Dr. Van Stavern, so she can talk to us today about stroke in the 21st century. Thank you for being here.
Oh, thank you so much for having me, and good morning, everyone. This is a subject I'm really passionate about, and so important that we all get educated about what stroke is and what to do with stroke, why it's important to recognize stroke. So with that, let me share my screen and just get a couple of things going here. All right, I'm gonna, good. It already says share sound, so hopefully we are in good shape. And we'll go from there. All right, let's see. Oh, screen sharing, but it didn't go to slideshow. Let's see. There we go. Now hopefully everybody can see my full screen. Again, we're here to talk about stroke in the 21st century. I work in the neurology department at Barnes and Wash U, and I have close collaboration with my colleagues in neurosurgery on this very important topic. This is our picture of the kind of the big campus down in the Central West End, right off of Kings Highway. It's, you know, when I show slides of St. Louis to my prospective junior physicians, I show them a picture from the Arch grounds, and 6 miles away from the Arch grounds, this mammoth complex is a little blip, but you can still see it from the Chamber of Commerce picture, so it's always impressive to me. And some folks would say that, you know, continuously under construction since 1957. This, I don't know if you can see my arrow, but the building over here on the west side is already torn down, and it's a hole in the ground because they've taken down Queenie Tower and they're putting up a big cardiology tower. So I don't really have any pertinent disclosures from a funding perspective. So for folks who don't know what makes our stroke program in our neurology department, and in particular just our whole program, unique, Barnes Jewish Hospital is the academic hospital for Washington University School of Medicine. You can't be a physician at Barnes unless you are faculty at WashU. And all of the physicians are professors of medicine in some capacity, anywhere from instructors of medicine all the way up to full professors. And this is a picture of the WashU undergraduate campus that I'm sure many of you recognize. So the other things that kind of make us unique, Barnes Jewish Hospital is the largest hospital in Missouri. We have magnet certification for our nurses, which is a recognition for excellence in nursing care. And we have had that, I don't even know for how many years, but we were one of the first magnet hospitals in the state. We've been on the honor roll for America's Best Hospitals by U.S. News and World Report for, I think, 23 years. I think that's what's on the big state, you know, the big poster as you enter the clinic. And we are the largest stroke center in the Midwest. Our department, just to kind of give you a perspective of who I am and where I come from, we have a huge number of neuroscience services at the hospital and through our outpatient clinics. Many of these have overlap with stroke, and those are in red. You may not realize that Alzheimer's and memory disorders have an overlap because those patients also have both blood vessel blockage strokes and bleeding strokes, and we'll talk more particularly about the blood vessel blockage strokes called ischemic strokes down the road. Gamma knife can be used for vascular disorders. There's a whole host of these, even sleep disorders, because there are concerns about and associations of sleep disorders with stroke risk, just like heart attack risk. So we have a lot of overlap with many of these subspecialties. We also have a huge group, and this is actually just a smattering of the folks who work in our stroke and cerebrovascular center. Of course, our stroke neurologists and our neurointensive care specialists, which our neurointensive care unit is actually run by a board certified stroke neurologist. We have specialists who do research in neurorehabilitation, a number of neurosurgeons and neuroradiologists who provide intervention and other clinical support, and then two emergency room physicians who have done separate stroke fellowships. This doesn't even cover all of our nursing and support staff who have done special training, who provide research support, who to provide administrative support to make all of this stuff work. So we tend to focus on the physicians, but I just have to give a shout out to everybody on the team, and it really is a team from the EMTs all the way through to at the beginning to the MAs who are scheduling the outpatient appointments. We couldn't do what we do without them. So let's, with that introduction, let's get a little bit into the nuts and bolts of stroke. So as mentioned before, stroke is huge, not just in the United States, but around the world. There are approximately 800,000 new or repeat strokes per year in the United States. It is now the 5th leading cause of death in the United States, with about 150,000 deaths per year. So the good news there is that either we're doing something right or some other diseases are doing something wrong, so to speak, because when I first started all of this in the 90s, stroke was the 3rd leading cause of death in the United States. And by about a decade ago, it was the 4th leading cause of death, and it's now the 5th leading cause of death. That was even before COVID and all of that. So lung diseases have kind of bypassed us considerably. So I think we're doing something right, and a lot of it is going to have to do with some of the things that we're going to talk about with early recognition and early treatment. And then it is the absolute leading cause of adult disability, with over 4 million Americans living with disabilities caused by stroke. For younger people, that are often things like multiple sclerosis, but as we age, and stroke is a disease of aging, just like heart attack, just like Alzheimer's, it is absolutely the #1 cause of adult disability. So what is a stroke? So now that I've used that term about 1,000 times already. It is an abrupt loss of brain function, so sudden, due to either a lack of blood flow to a part of the brain that's caused by a blockage of an artery, which is a blood vessel. This is called the doctor term for this is an ischemic stroke, or bleeding into or around the brain, and that is called a hemorrhagic stroke. There are a few types of those. Some of them are primarily caused by trauma. It's a smaller percentage of strokes, even including the traumatic bleeds. It's about 15 to 20% of strokes. We're going to focus on the ischemic strokes in large part because when somebody thinks they're having a stroke, you cannot tell clinically whether it is an ischemic stroke or a hemorrhagic stroke just by how the person feels when the symptoms start. It just looks like a stroke. And so a lot of the things that we're going to talk about for early recognition for ischemic stroke really are going to apply to hemorrhage too, because that early recognition is also helpful from the hemorrhage side. So this is a graphic of the Cincinnati Prehospital Stroke Scale. We were talking about how important it is to recognize when somebody's having a stroke. This is one of the scales that is used to teach paramedics how to recognize a stroke in the field when they get called. And this, we love this because it is so simple that it's great for teaching patients and families about what a stroke looks like. And so the things that put up the antenna, at least in a very basic way for what a stroke looks like, is first of all, you look at someone's face, and normally the face should move equally on both sides. Everybody has a little asymmetry, but no major differences. What you're looking for is one side of the face that is droopy or not moving. The second thing that we teach those paramedics is to look for what's going on with the arms. So they put both arms up, and if they can't hold one up the way that they normally do, again, that's a concern. And then the third thing is speech. And it says slurred or inappropriate words or not speaking. What I usually say is, slurred, not speaking, gibberish, not making sense, using all the wrong words. Any of that is abnormal for speech. And the reason why this scale is so important, I'm just going to advance one. Okay, good. The reason why this is so important is because there is an acronym called FAST. So F is for face, A is for arm, S is for speech. And then the T is for time, and that means time to call 911. And so if any of these things change suddenly, meaning 1 minute you're normal and bang, the next minute you're not, you go to bed normal and the next morning, your spouse or your family finds you with some of these problems. If any one of these things is suddenly abnormal, the likelihood of having a stroke is 65 to 75% that you're having a stroke. If any two of these things are abnormal, it's about 75 to 85%. And so this is a pretty good scale. It doesn't catch everything, but that's why it's fast, face, arm, speech, time to call 911. And we'll talk about why calling 911 is so important. Not going back to bed, not waiting and calling, your family who has to drive in from an hour away to come see you to then, take you to the emergency room, but call 911. And it's because we have some very time-sensitive treatments that can be helpful, particularly for ischemic strokes. But in addition to this, sudden numbness or weakness on one side of the body, so face, arm, leg, that's where that face and arm weakness, numbness also counts. Sudden loss of vision in either one eye or the one half of the vision in both eyes. Sometimes it's helpful closing one eye or and the other to kind of figure that out. Suddenly feeling like you are so drunk, and dizzy that you cannot walk without the assistance of another person. And this is, drunk without having had a couple of drinks or anything, waking up in the morning and whoa, I am done. I can't even hold on to the walls. I'm so dizzy. Any of those sorts of things, and there's even a few others, sudden double vision, are things that, again, are going to put up somebody's antenna and should put up somebody's antenna that they could be having a stroke. So I have a little video to play here that I'm going to narrate. It's, I think, about 30 seconds, just to kind of give you some additional insight into, it's a graphic representation of what happens with stroke. So here we have the body, and we're showing the brain and the blood vessels. You can see the blood going up through the brain. This is an illustration if you had a blood vessel blockage in, say, the carotid artery, which feeds the brain. You can see that these red blood cells and the white ones are platelets, are beginning to stick to the side of a blood vessel, and they can get a chemical signal that makes that stick quickly, and then a part can break off and go down into the blood vessels in the brain and block off the blood flow further down. And so what this looks like over time, and this is a CAT scan of the brain, kind of with the colors sort of superimposed for what this can look like over time. The red is the area of the brain that there are brain cells that start dying within 90 seconds of having a stroke, long before, sometimes even before people have realized that something's going on, but very early. So at 10 minutes, you may have an area of the brain that is already dying, and then the green area is the area that may be kind of stunned or injured, but hasn't lost enough blood flow yet to be permanently injured. Over an hour, that area that has died has expanded if there isn't an opportunity to open up those blood vessels. And at 3 hours, even larger, and then kind of chronically over hours to days to weeks, you can lose, potentially with a large enough blood vessel blocked off, like a carotid artery in a sudden fashion, you could lose about 2/3 of this kind of one half of your brain, or about 1/3 of the brain volume overall. So this is where time is brain. You can see that potentially, if folks are eligible, the earlier that we can get that blood vessel open in one fashion or another, potentially that's better from a stroke recovery perspective. We may not be able for folks to recover completely, but we may be able to help them recover a lot more than they might have if they aren't eligible for treatment. So here we have another little illustration. These are both free and courtesy of the American Heart Association website. So if anybody is interested in viewing these, kind of after this lecture, if there's any issues with the videos playing or you want to play them on your own time, go to the American Heart Association website. They have lots of great videos. And so this one, again, this is another illustration of the blood vessels of the brain. So again, this is a blood vessel inside the brain, and this is an illustration of that cholesterol buildup narrowing a blood vessel. And so what can happen is then a blood clot can come from somewhere else. Sometimes the blood clot can develop right there on its own, just from the cholesterol sending out a chemical signal that says make a blood clot here. That purple that went through is and we'll play it again. The purple that goes through is the clot busting medication called TPA, or tissue plasminogen activator. That's a mouthful. Most people just say TPA. And there are even some newer agents. There's one called TNK, which is very similar. And the idea is that when these blood clots form, if they come from somewhere else or they form in the blood vessel itself, then the chemicals in this TPA then help dissolve that blood clot and open up the blood vessel. All right, good. So the challenge with these treatments, and all of the treatments that I'm going to talk about today, is that there is a narrow therapeutic time window, meaning that we have kind of time-locked treatment. And the time starts from the last time someone was known to be well. So it's not when they wake up and somebody finds them with their symptoms. It's not when their family comes home and finds them with their symptoms. It was the last time they were known to be well. So if they go to bed normal and wake up with symptoms, then the last time they were known to be well was when they went to bed the night before. If they got up, made their coffee, start eating their cereal, and the spoon drops out of their hand and they start not making sense and speaking gibberish and somebody's sitting there watching them, then you may have an exact time of onset, or it may be, I was just in there while she was making coffee at 6 a.m. and everything seemed fine, but I walked in 15 minutes later while she's eating her cereal and everything went haywire. Then you have that last known well at 6 a.m. So IV TPA and TNK is coming, but TPA was the first FDA-approved drug for the treatment of acute stroke. It can only be given at a maximum of 4.5 hours after stroke onset and in select patients. So it's a challenge, for example, in patients who are already taking blood thinners for other medical conditions, as an example. If somebody had a major surgery 3 days prior, then of course that would be a challenge. So there's certain eligibility criteria, and they're very strict because that surgical patient could bleed from their surgical wound, right? This is a medication that it's sort of like being on blood thinners, but times 10. And so we have to make sure that patients are safe. But nationally, fewer patients than ideal are getting these treatments. Fewer than 5% of stroke patients get TPA. At our institution, the combination of TPA and some other treatments, it's about 20%. And we like to keep it that way. We feel like we work really hard to make sure that our patients get treatment quickly, and that as many patients as are eligible, we kind of get them into the possibility of a treatment pipeline. But it seems like with those numbers, perhaps there are some other options that would provide good therapeutic opportunities to more patients. So how do we make stroke therapy available to more patients? And one of the things is trying to see if we can enhance that therapeutic time window. One of the first things that happened, and this occurred a number of years ago, was the old time window used to be 3 hours. It's now 4.5. But perhaps there are some other treatments that might enhance that therapeutic time window even more, or things like delivering care faster. So as we've seen, potentially the earlier that you open up those blood vessels, the better people are, their outcome is, the better they're able to function down the road. And we've seen that in our clinical trials. So if we deliver care faster, we're actually making that time window work for us. We already talked about increasing eligibility, finding ways to make more and more patients eligible for early treatments. And then one of the things that we do is work closely with other hospitals, not just within the BJC system, but outside our system, we're continuing to expand the hospitals that we work with to try to serve other populations where they may need help with their stroke care. And so again, keeping this, kind of this CAT scan in mind, with the kind of the overlying illustration of how that stroke, in particular the area of dead brain that can't recover, expands with time. The flip side is TPA, we mentioned bleeding complications. One of the bleeding complications is bleeding into the brain. As you can imagine, the brain, when it's injured, it's kind of like other parts of our body when they're injured. If you smack your arm really hard, it swells, the blood vessels are kind of leaky, it bruises, right? And so the similar thing happens in the brain when it's injured. Those, the tissue gets injured, the blood vessels get kind of fragile, and so it's possible that patients can bleed. The good news is the benefit of this medication very much outweighs the risk of giving the risk of bleeding. So, for example, in patients who do not receive TPA, the benefit, or the likelihood of a good outcome rather, is about 10 to 11% of patients are going to be normal or near normal at the end of their stroke. If they get TPA, the likelihood of them being normal or near normal is on the order of about 32%. So there's a huge benefit there. The risks associated with it are that 6 patients may bleed. About 3 of those patients may be worse off because of the bleed, and 1 patient may die. And so this is one of those things that you've listened to those numbers. The benefit clearly outweighs the risk, but this is definitely a complication, and it's one of the reasons why we are so careful about making sure that the right patients get this treatment. We don't want this to happen in one of our patients who's on Coumadin or Eliquis, right? That's going to just ramp up their risk of bleeding. So it's the reason why we're careful. It's not because we're mean doctors and we don't want people to get these treatments, is that the things that we're always weighing that risk and benefit in an individual patient. So other ways we can make stroke therapy available to more patients. Maybe we need to try to get rid of the time windows where we can, or again, make that 4.5 hours, expand that even more. And so some of the things that we do that are using imaging tools to individualize this therapeutic time window, in particular MRI tools. So we do MRI imaging, and I have a colleague who has done research in this area. This is a patient who presented with left-sided weakness and numbness and got this type of MRI that looks at how the brain is using oxygen. And so here we have the patient's MRI at 2 hours. The United Stroke Scale is a measure of how severe a stroke is, with 0 being no appreciable problem with the patient's body, and 40 being the worst. I've never seen a patient with 40. About the worst I've ever seen is 30. And I've seen some pretty severe strokes. So 13 is considered, anything over 10 is considered a severe stroke. And so these are the patient's MRIs, and these are 2 basic sequences. But the colored sequence here shows how the brain is using oxygen. And so in this patient, the right side of the brain is over here on, actually it's on the left side of your screen. So what you see on the right side of the screen, you can see kind of the wrinkles of the brain. You can see that that's red on the surface, and that shows brain that is using oxygen to a high degree. What you see, and I think in this yellow outlined area, is kind of a purplish area. That purple color represents parts of the brain that are not using oxygen efficiently, as you can imagine, if a blood vessel has been blocked and it's not getting blood and oxygen. So we give this patient clot busting medication. And what we see at 6 hours in this particular patient, again, same MRI, really doesn't look all that much different on the basic images. But when we look at these functional images for how it's using oxygen, what you can now see, and we have it outlined in red here, is that purple area is about half the size that it was 4 hours earlier. So you can see where the blood vessels have opened up, and part of the brain is now beginning to recover and use oxygen much more efficiently. And then at a month, we see the patient's MRI. You can now see this little white area at the bottom of the screen on the middle series of images. This is a patient who has nearly recovered with an NIH stroke scale of 1. You see some of the residual from the stroke is that little whitish area there and a little bit of the whitish area there. And you have that outlined in red in particular there, the one kind of corresponds to what we were looking at on the colored scan. So you can see this is an even smaller area of the brain, even compared to the 6-hour image in color, that shows you where there was a much smaller area of permanent injury to the brain. And that's what this sort of image shows. So what else can we do? And some of what else we have been doing is trying to develop new approaches to more effectively dissolve the clots or remove the clots. And so what we do there is something very much anybody who's had a cardiac catheterization or a heart cath, what we do is a brain cath in these instances. So it uses a little spaghetti thin tube with a wire in the middle. And what they do is they run that guide wire just like they do if they were doing a heart cath from one of the groin arteries through the aorta. In a heart cath, they stop at the heart. In a brain cath, we send those guide wires all the way up to the blood vessels that feed the brain. These days, they also can do many of these procedures from the arteries in the wrist, which is more comfortable for many patients. And so when they do this, I'm showing you the images that that the interventionalists would be looking at as they're kind of doing this procedure. So what we have here, all these black squiggles are blood vessels in the brain. At the bottom here, the big black squiggle, that is the carotid artery. And so it's coming up, this is sort of right at the base of the skull, coming into the brain. And it ends kind of at this big branch here that goes out to that big portion of the side of the brain that we've seen injured in some of our prior scans and prior slides. And what you can see approximately where the red arrow is that it's like there's a stump right there. What you should be seeing is lots more blood vessels filling up this area. And this is the patient who got to the angio suite at about 4.5 hours. At 5 hours, this patient got TPA and some, which you can give through these catheters, but they also can do clot aspiration and clot retrieval in a similar fashion. So what you see here, there's that stump. They've injected a little bit of dye, just like they did here, and so you can still see the stump. They've inflated a balloon to kind of block the dye from going backwards. And then you see a little squiggle here with some little dots on the ends. Those are, that one's a blood vessel, but this one represents the guide wire where they've crossed through the clot. And now that they've removed the clot with a combination of a retrieval device and some clot busting medication, now you can see what I'm talking about. This arrow is in approximately the same location as this one. And look at all those squiggles you can see with the injection of that dye. You can see where those blood vessels have opened up tremendously after doing this intervention. So removing the clot through a combination of retrieval or with potentially some clot-busting medication through those little guide wires may be effective up to 24 hours after stroke onset. And this has been seen in a number of trials. The earliest one extended the window out to 16 hours, and follow-up studies have extended the window out to 24 hours. Again, there are very kind of strict rules about eligibility, how severe the strokes might be, which patients were included in the trials. So I wish every patient, we could make these things eligible for every patient, but we have expanded the number of patients who are eligible for treatment, where it used to be 4.5 hours, you were done. There wasn't a lot else that we could do. So now I have a little video that actually shows, this is an older device, but it's a great video that kind of shows this coil inside one of the blood vessels. This picture, it's kind of the patient's head is at an angle, but right there, that circle right there where you see the guide wire, it's kind of, that's the eye socket, and this is behind it. A lot of these blood vessels that we've been looking at live kind of right behind the eye socket. In the brain. These are some of your sinuses that live right above your nose. That's actually the bones of the nose right there. So now you can kind of get some perspective on, the patient's nose is coming out here. We've got eye socket there, another one there. And so these blood vessels are coming up here and right behind the eye. So let me play this, and hopefully y'all should be able to hear the audio as well.
He's going to be pulling it back. He's pulling the coils back.
And you can see how these are, delicate little vessels and kind of how flexible these wires are. All right. And this down at the bottom of the screen is what they pulled out with this, and they have other techniques as well, is a big old blood clot. These are tiny blood vessels. This clot was about, I think, between 1/4 and 1/2 inch long. That they were able to pull out of this blood vessel. And so you can see where you can get substantial benefit for these blood vessels, and you can actually see the clots come out. And in fact, we have researchers here who are studying these clots to see if what we can learn about them once they're out, to see if that helps us with other techniques to try to dissolve the clots more efficiently, better ways of removing these clots, understanding perhaps how they interact with the walls of the blood vessels or with cholesterol buildup on the walls of blood vessels. So there's really, once that clot's out of there, at least at our institution, we're not done. There's so much to learn to see if we can find out how 10, 20 years from now, we can be delivering even better care for stroke patients, because that's really our goal. All right, so the other things are looking at, there's a lot of research going on with drugs called neuroprotectants, meaning things that maybe if you gave them in the ambulance when somebody's thinks they're having a stroke, it could improve the likelihood that they would have a good outcome down the road, or perhaps improve the likelihood, make it easier to remove that clot. Unfortunately, we're not quite there with neuroprotectants. I think at this point, at least 35 different drugs and chemicals have been attempted to see if we could use this, and it just seems like it would be so easy. And unfortunately, we have not found any that have that great risk-benefit ratio. Usually it's, most of these chemicals, there's really just been no benefit beyond the treatments that we're already providing. So we're still looking for that holy grail of something that our paramedics could give in an ambulance, that somebody would know to give at home. Oh, I have, they tested magnesium supplements a number of years ago. Let's give somebody a high-dose magnesium supplement out the door and see if that helps. And unfortunately, we just haven't hit that yet with the holy grail of neuroprotectants. So the other thing that we do to make stroke therapy available to more patients is we have a network. We have a lot of hospitals that we work with. You notice not all of these, and these aren't even all the hospitals that we work with, but not all of these are hospitals in our own system. We work with Ozarks Healthcare out in West Plains, Missouri. That's about a 4.5, 5-hour drive from here, over near the Arkansas border, kind of between Branson and Springfield. We work with South City Hospital. So we work actually with a St. Louis hospital in an area that is underserved by neurology specialists, that isn't affiliated with any of the major health systems in St. Louis, to try to help them provide better stroke care for a population that really, really needs it. And then Belleville Memorial wasn't always part of the BJC system. We've been working with them for over a decade to elevate the stroke care in Illinois. And that's one of those things we've really been able to accelerate that since they've joined the BJC system. So this whole thing is called a stroke network of care, where we share resources with network hospitals. So then you may be asking, well, gosh, this is a huge area. Ozarks Healthcare is 5 hours away. How do we do that with 10 stroke neurology specialists? Well, the way we do that, and this was even before COVID, is with telehealth, using technology, computers, video cameras. We've been doing that in a variety of hospitals in this region. Actually, when I came here in 2009, I was tasked with helping Barnes choose their new platform for delivering telehealth. So again, not new things. I was doing telehealth. I was in Detroit before I came here, and they had telestroke as part of their model, even going back to 2003. One of the folks there was kind of an early adopter with telehealth. But the idea is you have, and these days it's actually an iPad even more than kind of a rolling robot, but you have a doctor with a computer screen, with a computer and a screen, and you have a patient in a hospital somewhere else where there's a camera of some kind, again, often much smaller these days. This is just such a great picture. I continue to use it. But, you may not have that camera above, but basically with the iPad, where you can see the doctor can see you, and the iPad or the robot is mobile, so it can see, it can move or be moved and see your whole body. It actually, most of these cameras, just like the one on your phone, have zoom capabilities. So I can take that picture and kind of pinch it wide and focus right on somebody's eyes, so that I can look at how their eyes move, for example, with something like this. So it's really remarkable technology. We're using it now in clinic settings for a variety of patients, but we've been using it in stroke settings. It's been validated for acute stroke for a decade or longer. And so kind of the nuts and bolts of how this works, again, you have a doctor that can be sitting at home, can be sitting in their clinic. For one of my colleagues on vacation, which I don't advocate to any of my junior doctors. They need a break and they need vacation. But the point is, anywhere. Actually, I think it's not on vacation. He's done it from the airport. You can find, it's secure. It goes through broadband internet that's encrypted and HIPAA compliant. That's required for all of these systems. And then it goes to either a robot or an iPad on a cart that are all FDA cleared and compliant equipment. So for example, Missouri Baptist, which is one of our partner hospitals, microphone, web camera, again, might be what's available on an iPad these days, and allows the stroke faculty on one end to interact with the the doctors, the nurses, the patients, the families in the emergency department. We'll often have an initial phone call because we don't need this technology for every patient. If this is a slam dunk, this patient needs TPA and needs to be shipped to Barnes for an interventional procedure, I may not need the robot for that, or the telemedicine technology for that. It might be somebody where things are a little bit trickier, where it's not clear for the ED physicians what's going on, or the ED physicians aren't sure that the patient really understands or their family understands what's going on with stroke, or it's complicated decision making. They're on a clot busting medication, and so they might not be eligible for, or they're on an anticoagulant, so they might not be eligible for the clot busting medication, but they might still be eligible for the inside the blood vessel interventions. So those are kind of advanced discussions that are often better done by neurologists, and in particular stroke neurologists. And so then we have those conversations and can make those decisions exactly as if the patient were sitting right in the Barnes ER, where we could talk to them as well. And so here we have that mix of the, time is brain, right? We have the picture with the clock and with the brain, and so if that clock ticks for you or a family member, answer that call. Call 911 if you recognize that they're having a stroke, because this is so important. The American Heart Association has stroke as an umbrella underneath it because there's so much overlap, and they have great educational tools on their website, not just for stroke, but for the other conditions that can contribute to stroke, which is a whole separate topic and really even beyond the scope of what I was asked to talk about today. So as advertised, I think I said this, I thought this would run about 45 minutes, and I think I'm pretty close to that. With that, I will pause. I can see that there are a number of questions in the chat, and so I will stop sharing my screen and see if we can take a look at some of those questions. All right, so, and these look like they're in order, so I will do my best to take them in order. All right. Oh, so were y'all not able to hear me very well?
No, we can hear you. If you could just move your microphone down.
A little bit more. I'm sorry. I wish I'd known that at the beginning. So I couldn't. It's hard for me to do the chat and see the screen at the same time. Is that better?
That's better.
Okay.
Yeah.
And so clarify. So the first one is clarify the difference between neurologists and neurosurgeons. That is an easy one. And the biggest difference is surgeon at the end. So for neurologists, we take care of the conditions that affect the brain and the nervous system that they may require surgery. We don't typically do the surgery. So we have some neurologists that have the radiology training to do these interventional procedures, just like radiologists and just like neurosurgeons. But we're not going in and taking off somebody's skull and clipping an aneurysm. We're not opening someone's vertebral artery, or vertebral bodies, their spinal column, to do a neck surgery or a low back surgery. We don't take out brain tumors. I might diagnose one, I might diagnose an aneurysm, but I would then refer the patient to a neurosurgeon for the surgical techniques to address that. So neurologists take care of stroke, epilepsy, Parkinson's, Alzheimer's, multiple sclerosis, other kinds of tremors, variety of different conditions, but we may be kind of adjacent as far as what's going on from a surgical perspective. Some of my colleagues in movement disorders are in the operating room when, say, certain Parkinson's patients are getting surgical procedures to address their Parkinson's, but they're not the ones doing the surgery. So that's the easiest way to think about the difference between a neurologist and a neurosurgeon. All right. So initial numbness on one side of the body lasts minutes, no evidence on the CAT scan, and corrects in the space of an hour or so. Is that a TIA, and is that a form of a stroke or with longer term consequences? So that's a great question. So the question is kind of, depending on the timing, what do we call it? And is it the same thing as a stroke? And the answer is kind of, for all intents and purposes, TIA and stroke are the same thing. When we think about heart attack, right? Chest pain, angina, it's the same thing, right? That is the warning for a heart attack that's coming, right? For a TIA is a warning for a stroke that could come. A small percentage of those might actually be a stroke that was so small that the body recovers from it within hours. We call a TIA neurologic symptoms that recover in under 24 hours and don't have any visible evidence of the stroke on imaging. We don't always do imaging because it doesn't change what we do, right? If that TIA is a warning, it's transient ischemic attack, but is a warning for a potential stroke down the road, we, just like the cardiologist, we are doing exactly the same things that we would do if somebody rolled into the emergency room and their symptoms had not recovered. So we're evaluating all of that, trying to evaluate all of that quickly. Whether that's that can be in an inpatient setting, that could be in an outpatient setting, depending. But yes, that's one of those things that would often be called a TIA. The reason we do the CAT scan at the beginning, honestly, we can't see a stroke at least half of the time on a CAT scan in the emergency room. But the reason we do it and don't do an MRI is, number one, CAT scans are still the best test to distinguish a bleeding stroke from a non-bleeding stroke, from an ischemic stroke. And that's really important if you're going to give clot-busting medication. We can't tell the difference clinically, so we need to know, because that radically changes what we're looking at. And then number two, MRIs take time, and not everybody is eligible for one. And so for a lot of the guidelines and protocols, again, we're trying to make as many people eligible as we can. And so with MRIs, if you have, a pacemaker, you often can't get one, or you can't get one quickly. You have to go through 4 levels of the magnet safety before your body can even get into the scanner, and then all the way back out of that. Even with the very best timing, that usually takes 30 to 45 minutes. Again, with time being brain, using MRI on everybody in the emergency room can take some extra time. And so we look very carefully at what our times are for delivering TPA. So anyway, that was kind of a long answer. But yes, TIA is a part of the stroke, is in the timeline of a stroke, just the same way that chest pain is for a heart attack. And I'm assuming that was 81 milligrams of aspirin daily prevent, this is TPN, but I'm assuming that was TIA. So TIA and stroke, yes, it can prevent those. Now, the best evidence these days is that people shouldn't be on aspirin on a regular basis unless they have had a stroke, a heart attack, blood vessel blockages in their arms or legs, or warnings for any of those. There are other conditions. You have a stent, you have metal wire somewhere else. But if people have never had those things, there is not a clear concern. It's actually something to talk to doctors about. If it's just, oh, this seems like a good idea, I should be on an aspirin. Talk to your doctor about that. I'm not going to, I'm not your doctors. I'm not going to tell you not to be on it. But some of the current guidelines are just want to make sure that we're balancing the benefit with the risks of bleeding complications. And then let's see, no blood thinner guide. Related to the no blood thinner guideline, does this include aspirin, especially in a patient taking aspirin related to a possible TIA, where the primary care and neurologist disagree? So this is a great question, and this comes up all the time. Aspirin is actually not a blood thinner. People often call it that because it's easy to think about it that way, but it really doesn't thin the blood. If you take a pen and prick the end of your finger and let the blood drip on the ground, the time it takes for your blood to clot on aspirin is exactly the same as it is off of aspirin. So it's not truly a blood thinner. Blood thinners actually usually make it 1.5 to 2 times as long for your blood to clot if you prick your finger. And so, so aspirin does not make people, people are still eligible for TPA and for all of these treatments if they're on aspirin, even with the blood thinners, depending upon the institution you go to. And it's, again, that's something that we've looked at very carefully. We have some very strict protocols based on our own laboratory data that patients who have taken blood thinners might still be eligible, particularly if they haven't taken it, say, in the last 48 hours. So there may be some, again, that's one of those things, not every institution does that, so I'm kind of trying to keep this broad, but there are some instances, and in particular for the intervention procedures, the ones that go up through the blood vessels, at our institution, and I know others, that even people on those medications, they are often still eligible for those intervention procedures. All right. Let's see. TPA. Oh, it said TPA. Good. Then I think I answered that question. Which hospitals in the St. Louis area are as up to date as Barnes for strokes? I'm not on their committees, so I don't know for sure. However, and again, this is one of those things, we work together. I think it's great that we have such terrific neurology in St. Louis. So this is where I don't have any heartburn talking about, our competitors or whatever. SSM has strong neurology and stroke. Mercy has strong neurology and stroke. St. Luke's has strong neurology and stroke. And so the hospitals in those systems, if they don't have their, I know, Mercy and SSM have their own programs. I think St. Luke's often partners with some others, but it doesn't matter if they partner with somebody else. Terrific. We just want people to get great stroke care, and I know they have a stroke specialist at St. Luke's who has been really driving that program. So yeah, there's what we say with stroke is you call 911 because you want to go to the nearest, closest hospital. You don't want to get in somebody's car and drive, 2 hours from, somewhere in middle Missouri to come here for a stroke. Again, we're not the only game in town, and we want folks to get treated as early as possible. So go to the nearest, closest facility, because even if you get most of your care, say, here at Barnes or through WashU, but you live closer to an SSM facility, they have terrific stroke protocols. And so, you're in good hands in all of these systems, because we're all trying to follow the same guidelines. How can you find an online list of hospitals with intervention or clot retrieval equipment? So the best way to look for that, to the best of my recollection, is to go to, it's the Joint Commission, or TJC. That is a hospital accreditation, the major hospital accreditation organization. They accredit hospitals both as primary stroke centers, which means that they can give TPA, all the way up to comprehensive stroke centers, which are centers that typically do intervention. There are a few grades in between, but the Joint Commission definitely has that listed. And has the diagnostic equipment and the treatment capabilities. Let's see, national and international hospitals. And so when you what to do when you travel, we talked a little bit about the region. So when you travel, the good news is, in the United States, even in rural areas, because this is so important, most states that, like Idaho, for example, has a large rural area, right? But they actually have because of this, they actually have a well-designed system of care for telehealth, air ambulance transfer, even for rural areas, to get them the care that they need. So most places in the United States, again, you call 911, you're going to go to the nearest closest hospital, or they may even send an air ambulance out for you. internationally, if you're in Europe, Europe actually has had better what we call door to needle times, but better treatment times for TPA and intervention than we often do in the United States, in large part because the geography is so much smaller. In some areas you can't throw a rock without hitting a stroke capable hospital. It's a bit of an exaggeration, but you can't go 30 minutes without running across a stroke capable hospital. And so, if you're going to be out in the middle of the Sahara Desert, you've got a problem, right? There's just not going to be resources there. This is kind of common sense. But for most of the major metropolitan areas, not just in the U.S. and in Europe, but around the world, these are established treatment protocols. South Africa has stroke care. One of my former colleagues, he's a Parkinson's neurologist, but he has worked very closely with the folks in South Africa and has been very impressed with the care delivered there, as an example. Would low-dose aspirin count as a blood thinner? We already talked about that one. What is the clinical effect of aspirin if it's not a blood thinner? That is a great question. So if you remember that one of those animations that had both the red blood cells that looked like red donuts and little white spots also floating through the blood vessel. The white spots are called platelets, and aspirin works on the platelets of the bloodstream, which is a part of blood clotting. It's not the strongest part. It's actually relatively weak, but it is an important part where stroke and heart attack are concerned. Blood thinners work on the far more powerful proteins in the bloodstream that cause far more major blood clotting to occur. And so this is kind of the difference, is that the blood thinners work on proteins that are more powerful for blood clotting. Aspirin works on the platelets that are much weaker, part of that blood clotting cascade. Somebody saying, I'm taking Eliquis, so I wouldn't get TPA. Again, kind of depends on the institution and what their protocols are. But in many instances, again, if you'd taken it that morning and 2 hours later you had your stroke, that would make TPA problematic. It would make it a challenge. Again, we're working on ways to try to expand that. There is a reversal agent for Eliquis that folks are beginning to do some research to see if that's safe to use in acute stroke situations, to see if we can, again, further expand the use of some of these medications, things like TPA in the acute setting. We're just not there yet. But yeah, it's one of those, it's kind of that's true, but, or that's more information to come, I think, as we get more research. Mic is still a problem. Should you use a remote mic? Okay, yeah, I've used this mic for a lot of things. I've not had folks tell me that the breath issue was a problem, but I apologize for that because I had no way of knowing in advance. What other questions do you guys have for me? I know we just have a couple of minutes left.
Any final questions or thoughts? Well, everyone, well, thank you very much for being here today. I took a lot of notes. I thought this was such a fantastic presentation. I wrote down fast so that I will remember face, arm, speech, and time. I loved the video too. I thought it broke things down so simply to explain what a stroke is, why it happens. So this was fantastic. Thank you again for being here. I know how busy you are, and this presentation today has been recorded, and anybody can look at it again to review the material. I know we covered a lot. So everyone, have a wonderful day, and thank you again, Dr. Van Stavern.
Oh, no, thank you. Y'all have a great day.
Okay, bye-bye.